this distinguished panel is going to be about stem cells and about the use of stem cell therapies in autism from various different perspectives. And I will not waste any of your time, but I will just take the moment to introduce our four distinguished speakers at the panel. The first one is Jihan Abazovich. Dr. Jihan was born in Ulcinj in 1982, sorry. He's the oldest child in a family. He completed elementary school and high school in Ulcinj and completed the medical faculty at the University of Belgrade. He has continued his education and earned the title of emergency medicine specialist at the medical faculty in Belgrade. In addition to obtaining a formal education, he enhanced his knowledge by practicing regenerative medicine in numerous countries, namely Brazil and the Netherlands. In his professional career, his interests are not limited just to the field of emergency medicine, which he practiced for a long time, and he was head of the department in Ulcinj. His interests actually expand to the field of regenerative medicine, closely dealing with the use of stem cells and blood derivatives as one of the pioneers in this region. In 2013, Dr. Abazovich made the decision to focus on regenerative medicine, first at the Renova clinic, where he also served as a medical director, and then expanded his knowledge and skills through collaborations with other clinics. His interests in science has not lagged, and is reflected in numerous published scientific papers in the field of regenerative medicine in world-renowned journals. Today, Dr. Abazovich is a frequent lecturer by profession and an educator for the use of blood derivatives and stem cells for various indications around the world. He is also a co-owner, founder, and director of Vincula Biotech Group. This is the company that consists, among other things, of two hospitals, one in Belgrade and the other one in Novi Sad, where the latest medical procedures are being performed. Please give a warm round of applause to Dr. Abazovich. He will be our first speaker.
Thank you very much. Thank the organizers to give me opportunity and chance to exchange the knowledge with the colleagues and the parents. And congratulations to the organizer, because you really managed to bring leading world people in the one room and making them talk in front of the patients and patients' parents as an audience. So this is a very, very big achievement, and again, congratulations from my side. So I will try not to be so long, and I hope that you will have a lot of questions and we can discuss about everything what you are interested in. I will talk today about bone marrow stem cells therapy. First of all, if we want to make some introduction, we are using today, when we are talking about autologous stem cells. So autologous, it means that we are taking the cells from the patient and giving back with minimal manipulation to same patients. There are three actually ways how we can obtain these stem cells. We can obtain them from bone marrow, we can obtain them from the adipose tissue, and we can obtain them in some cases from circulatory blood. In cases of autism, we are not using stem cells from circulatory blood, because in addition to get stem cells from the different sources in the blood vessels, you need to give some medicaments which we don't consider so safe in autistic children. Actually, they are interfering a lot with immunological systems, so we are trying to avoid circulatory blood as a source of stem cells. Mainly in our daily practice, we are using bone marrow, and when we are talking about bone marrow, you can actually withdraw the bone marrow from almost all bones. Mainly we are using iliac crest. So this is this bone on the above the hip, actually pelvic bone. We can use the proximal tibia, which is bone under the knee, and we can use some other sources. Actually, after we are withdrawing, which process you will see during the presentation, after withdrawing, we are separating the cells. Separation is done by simple centrifugation, but we are using some equipment which have sensor control technology, and it obtains us to get as much as possible stem cells from the bone marrow. How does it practically work? So I will be as easy as I can. You take amount of bone marrow which is 100 or 150 or 200 milliliters, and from that you are, by using of centrifugal forces, you are, let's say, squeezing the stem cells in one small portion. So from 200 milliliters you are getting as end product 3 or 4 milliliters of something what we are calling bone marrow aspirate concentrate. Why I'm underlining this is because these are not the purified stem cells. These are the stem cells with, this is the substrate which beside the stem cell it contains all the other lot of other cells, including erythrocytes, platelets, and other cells which we can find in the bone marrow. So simply the process is that we are placing the special needle and we are withdrawing in the spongious part of the bone. Spongious part is that part which looks like sponge, so it's approximately half to 1 centimeter from the bone when you are getting through periost, and we are getting out the bone marrow. This is how the process is looking. So this is a special needle, and we are drilling it inside the bone. Whole process take about 2 minutes. We are making one very small cut, and we are even not putting the stitch on this cut. And we are opening this special needle, as you can see, and we are withdrawing the bone marrow. So maybe what is most important for you as a parent, and if you decide and fulfill criteria for having this therapy, is to know that this procedure all in and out takes around 1 hour, and this is 2-step procedure. First step is withdrawing of bone marrow, which takes around 5 minutes. And after that, we are not waking the patient up. It's still on the anesthesia, but we are not doing anything on the patient. We are separating the cells, and the process of separation takes around 20 to 25 minutes. After that, there is a second step on the patient, which is another injection, and it also takes 3 to 5 minutes. So this is a very, very minimally invasive procedure as a procedure. What is very important for us is that we are doing very strict quality control. So as you can see, we are doing 7 CD markers in order to differentiate hematopoietic and mesenchymal stem cells. They are four of these 7 parameters are more than enough to do this differentiation, but we are following some specific cells, and you can see some of our results on this slide. What is an important thing is that from these stem cells we are expecting paracrine effect of them. So we are not expecting cell as a cell to do something and to be differentiated, but to release some components which will helping to modulate immune system, and maybe this can provoke better clinical outcome of the patient. This is done for each and every patient. In opposite to this, we also have manufacturers which are producing the stem cells. This means that we are able to cultivate the stem cells and multiply them. Unfortunately, this process is, if you want to do it according to European regulation, they are they are much more expensive, and at least here in Serbia, the legislation, it's pretty complicated to use this kind of product. This is the reason why we are mainly use the autologous stem cells, but we are all hoping that this legislation will be in the next few years easier, and we will have a chance to help more patients that we are doing this today. Specificity of our approach is that we are using the intrathecal application of the stem cells, and on this point, I will leave Professor Marić to continue with the presentation. Thank you very much.
Thank you. I would just like to invite Professor Marić, but I will just briefly say who he is. He's a pediatric surgery specialist and orthopedic specialist. Since 2015, He's the head of elective course Regenerative Medicine in Integrated Studies and the head of Regenerative Orthopedics in Doctoral Studies at the University of Novi Sad. In regenerative medicine, his focus is on neuroregeneration, robotic rehabilitation, cellular signaling in orthopedics and neurology, as well as stimulating the activity of stem cells. His latest scientific papers focus on homing mechanism for stem cells in intrathecal application. He's also a co-founder and co-owner of and Chief Medical Officer of Vincula Biotech Group, founder and president of the Orthopedic Society of Serbia, co-founder and co-vice president of SEBRA, a member of Scientific Committee of Global Regenerative Academy. His efforts in the ecosystem of Vincula Biotech Group include BTOA, biological therapy of autism, and BTOCP, biological therapy of cerebral palsy. Please, a warm round of applause for Professor Marić.
Thank you. I will be as short as possible. Basically, we apply in autistic and autistic spectrum disorder patients, we basically apply stem cells intrathecal. Our main substrate is bone marrow aspect concentrate, but to explain you why. Because we analyzed homing of the cells and analyzed literature after many different consultations with colleagues, we concluded that there is no one clone of cell that can produce adequate biologic reaction or adequate biologic immunomodulation or remapping immunological disorder map in a body. It means that we should apply at least 3 different clones of cells to do something new. As we all know, shortly in autism, the basic problem is that information that are generated from the periphery, they are basically analyzed in a frontal and temporal region of the brain. In autistic patients, they are analyzed in an occipital region. There is no hardware to analyze promptly those information, and we should restore some neurological circuit. In order to restore neurological circuit in those patients, we concluded that at least 2 different clones of mesenchymal stem cells should be given, and at least 2 or 3 types of hematopoietic stem cells, of course, the first CD34 plus as the leading clone. Why? Because the one type of mesenchymal stem cell will come down to disordered immunological reaction of glia in the brain. The other will correct axis between brain and gut, and then they will make a normal barrier between brain and blood, between gut and blood. And the most important is that hematopoietic stem cells can restore neural working of neural synapses. In that matter, we developed some protocol that there is not only it is not only intrathecal region is important. It is important to get stem cell in the brain in some way. When we apply stem cells intrathecally, we apply stem cells with the stem cell niche. Stem cell niche is a big unit, and it serves with to produce a lot of microvesicles, proteins that will awake dormant stem cells on the roof of the 4th chamber or on the gyrus hippocampus, both for the cognitive or motor improvement. And the second part is very important, to do some cells to transfer with intranasal drops or via olfactory nerve. Because one type of cells goes to the cerebrospinal liquor, the other goes with the interstitial part of the brain through the brain lymphatic system. Brain lymphatic system exists, and it is called the lymphatic system that is very important for good neural metabolism. In this order, combination of these two parts can give the most optimal response to body, to child, in order to get most of the symptoms that we have in autistic patients that are covered. So we analyzed cerebrospinal liquor. We concluded that cytokines are very, very sophisticated proteins in the brain, and that guilty cytokines for reducing inflammation or improvement in treatments are interleukin 27 and interleukin 17. We registered very big level of decreasing those two cytokines in children that have big improvement. We are about to be published our findings next month in a Journal of Biochemical Molecular Science, just in order to show that we are targeting good thing. For the conclusion, we should strive to one thing, to personal therapy according to a patient, and try to mimic embryogenesis. It means with any type of cells that we can isolate and give, we should try to imitate period of development of embryo when the child was perfectly healthy, and try to mimic and initiate genetic or gene cascade that will repair damaged immunological network. Thank you.
Thank you, and apologies for the technical difficulties with the presentation. I think it will be sorted out. Apologies to you in the room and everybody following us online. The next panelist is Stanislav Volchkov, MD and PhD. Dr. Volchkov is the Deputy Director of the Samara Regional Medical Center, Dynasty, the Executive Director of the non-profit Hematopoietic Progenitor Cells Registry, expert of the Food for Assistance to Small Innovative Enterprises in Science and Technology. He's the founder of the Institute of Biotechnology and Pharmacology in Biopharma, LLC, and is certified designee for the biomedical cellular products acquired by Ministry of Health of the Russian Federation. Please give a warm welcome to Professor Volchkov.
First of all, I want to say very big thanks to organizing committee because this is a big opportunity to share our work, and it's a great opportunity to listen to the real professionals from colleagues. So I will do my short presentation. The clinical trial we're doing now is called Safety and Efficiency of Transfusion of Umbilical Cord Blood in Patients with an ASD, depending on the degree of HLA capability. So it conducted with Medical Center Dynasty with cooperation with NBio company and International Bioclinic company. This is a prospective, non-randomized with control group study. It will involve in 150 patients in 3 groups. One group is HLA, high HLA capability. Means that we tested patients and tested donors for HLA compatibility, and if they matched for at least 4 loci, it's called high HLA matching. If not, this is the second group, low HLA compatibility. It's less than 4 and less HLA loci matched. The third group is the control. So the overall protocol contains with 2 infusions of cord blood within the 6 months from the first to the second infusion. The cord blood is matched by group type and rhesus, by HLA and by cell dose. So we prefer the cell dose is about 1 million cells per kilo of the patient. What we can say about the cord blood? So it's allogenic cord blood, and we have common advantage of the cord blood is following. It is safe. It's used for transplant for more than 30 years as a hematopoietic stem cell source. It's highly active because they harvested in newborns, and it also can be called as the youngest adult cells. And it contains much different cells, not only hematopoietic stem cells, but much more different cells. And these cells have immunoprotection and immunologic preferences. So here on the right upper slide, you can see some systematic review of clinical studies with cord blood that also shows the safety of this procedure. So, and we also have the private advantage because we used cord blood from the cord blood collection facilities that is collect cord blood, processed and stored. And this is facility is accredited by Immunogenetic European Federation of Immunogenetics. It's worldwide Marrow Donor Association and also ISO accreditation. So this is the most effective bank in Russia. It have more than 50 transplants worldwide and more than 200 plus cord bloods used for regenerative procedures within the clinical trials. So the application is intravenous because it shows its most safety procedure. It can be done without even without sedation, what is the patient is sensitive to. So IV application is still effective because mononuclear cells can pass the barrier if it's damaged, and with ASD it can be damaged. And what is working more is that it's not the stem cells itself, but it's secretome. It's cytokines, it's exosomes, it's messengers, and it's also small molecules. And here's some systematic reviews and meta-analysis of big clinical trials and data from the clinical trials that shows effectiveness on the cell delivery within the different methods. It's almost safe. So we use this safe method, I mean intravenous infusion. So we have some inclusion and exclusion criteria. It's inclusion criteria from for 14 years, diagnosis of ISD, and disease severity not less than 16 points by attack scale, and compatible allogenic specimen suitable for infusion, and of course consent of parents. For exclusion criteria, I think just say it's a wide range of diseases in active stage, and cerebral palsy and Fragile X chromosome syndrome, and the seizures and epilepsy. This is the exclusion criteria for this treatment. It's the typical procedure looks like, so it consists of 4 stages. First 2 stages can be done via online consultations. The stage 3 is infusions, and stage 4 is continuous assessment, which starts from the first infusion. We ask parents to complete the attack scales each month. So the procedure itself will proceed done in Samara, where the parents need to be stay at least 5 days. The first day is they going to meet the team, take the blood draws, to do some tests, and On Wednesday usually is for the infusion day, and the Tuesday is a checkup date. After that, the patient can go home. So our results, we enrolled 40 patients, and the cord blood infusion we received only 25 patients because we start this procedure in just a few months before the COVID situation goes, and after that we forced to stop our trial. So as I say, 25 patients received the cord blood infusions, and here's some results. You can see about 76% have behavior changes in better or excellent in summary, and just only 7 patients received these 2 infusions. Almost all patients stop after 1 infusion because boards was closed and nobody can go to the second infusion. And we have some one publication only within these temporary results, and also I give you some links to the medical papers, which is the same protocol from our colleagues, and it shows the efficiency and safety of stem cell therapy in children with autism spectrum disorders. So this is some pictures from the clinic where we have some different equipment, and this is a picture of the team who started this clinical trial and the facility of cord blood bank. So I think that's all. The further studies, we're going to start the new studies, and I just say you a little. It's actually low-matched cord blood infusion, but these cord bloods will be selected by Q receptor. And we also want to start the combined umbilical cord and mesenchymal stem cells infusions, because the mesenchymal stem cells is more immunomodulatory state, and the cord blood and the hematopoietic stem cells is more just for neuroprotection. We also want to use the MSC exosomes and combined with cord blood, MSC exosomes alone, and we also want to use CD14 positive cells exosomes and for CD40 plus positive cells for infusion alone, because there is some data that CD14 plus cells have very neuroprotective and neuroregeneration capability. So here's the contacts of our clinic and our center, and thank you very much.
Thank you. And last but not least, I hope I'm pronouncing your name right, Magdalena Chrościńska-Krawczyk. Is that right? Okay, good for me then. MD and PhD. She's a pediatrician, pediatric neurologist specializing in clinical genetics. She's an assistant professor at the Department of Children's Neurology of the Children's University Hospital in Lublin, academic lecturer, and she also cooperates with the University of Economics and Innovation in Lublin and the Catholic University. Dr. Krawczyk is a graduate of the Medical University of Lublin. She defended her PhD in the field of pharmacotherapy of epilepsy. In 2009, she received a research grant from the Ministry of Science and Higher Education, which resulted in a habilitation thesis on the impact of chronic use of methylxanthines and the effects of epileptic drugs in an animal model of epilepsy. She's also consulted in the field of child neurology in the province Lublin. At the Department of Pediatric Neurology, she conducts innovative therapies with the use of umbilical cord stem cells and autologous umbilical cord blood in diseases of the central nervous system in children, implementing the cord blood for cerebral palsy and autism program. She was the first in Poland to use the gene therapy in the treatment of spinal muscular atrophy in children. Of particular interest to her are neurological rare diseases, cerebral palsy, and this interdisciplinary approach to childhood disability. Dr. Krawczyk is an author of many scientific papers, reports, academic textbooks, and she's a lecturer at national and international conferences. Please give a warm round of applause for Dr. Krawczyk.
Thank you very much for introduce. It's all about me, really? No, it's not true. Thank you for introduction and for invitation on this conference, especially in this difficult time, not first of all because of pandemic, and the second because of this terrible war in Ukraine. So I hope that will be finished, because the children and women suffering because of them. But I hope that will be finished soon. So today I would like to tell you about the use of mesenchymal stem cells in children with autism in our clinic. What the procedure of looks like in our patient. In our treatment, we qualify patients in diagnosed childhood autism with or without mental retardation. The exclusion criterion is the presence of drug-resistant epilepsy. Why? Because of possibility of aggravation of seizures after stem cells therapy, after mesenchymal stem cells usage. Our protocol is when we start with our protocol, we read about a lot about the Professor Kurzberg from Duke University treatment and clinical trials, and on the basis of these trials, we and do our medical experiment with usage mesenchymal stem cells. What with application procedure? They are 5 injections and they are intravenous injection. And the interval between injection is about 2 months. Assessment by psychological test, main it is ADOS test. It was before the first use of mesenchymal stem cells and before the 5th administration. What we know about mesenchymal stem cells? Mesenchymal stem cells, like other stem cells, are characterized by the ability to renew themselves. A single cell has the ability to differentiate into multiple cell lines and in vivo is able to reproduce tissues into which it can differentiate. And they have an immunomodulating effect, what is very important in children with autism. Mesenchymal stem cells are also defined by their differentiation potency and expression of cell surface markers. You see these markers and lacks expression of the other markers which are connected with inflammatory process in central nervous system. Now in our clinic we have 50 children with autism after therapy, because apart children with autism we have also children with cerebral palsy. But in children with autism, after therapy now with 50 children, during therapy 45. And what we see improvement, especially of cognitive function. It is evaluation of therapists by testing characteristics of autism, reducing of aggressive behavior, of course, also evaluation of therapies. What is very, very important, it is probably connected with plasticity of brain in children, that the better results we observe in younger children up to 5 years of age. And what else? We observed especially improvement if some cognitive function like concentration, memories, and reduction of aggressive behaviors. It's a little bit that improvement in of cognitive function, especially cognitive functions are better after mesenchymal stem cells therapy. But we must remember the better results we observed in younger children up to 5 years of age. And here is our private clinic, Żagiel-Med in Lublin, in which we have this program with the use of mesenchymal stem cells therapy. And here is my email address. If somebody is interested in this therapy, you may write to me. Thank you for your attention.
Thank you to all the panelists. We are now going to discuss this, and if you have any questions, please go ahead. But before we proceed with questions, I would just like to thank all of you, personally, because I think what is being done in stem cells is really something that is cutting edge, and we know that people have different views on this. Some think it's a silver bullet and it will solve everything. Some people don't believe in anything. But I think unless we do a lot of work and the precious work that all of you are doing, I think we will not get the answer to that, and we need the answer to this question. And I think this is, especially interesting for me because I think as a parent, we were discussing which stem cells to use, which approach to take, and this is, I think, a very useful panel in that we look at the same problem with different views, and we see that there are promising results on all that. So thank you once again for that. Do you maybe have some questions for one another? I saw that you were looking at each other's presentations with curiosity. So, unless you had a chance to discuss it between yourselves, is there something that you would like to ask some other panelists?
I have a question of considering the safety, because we are talking about two ways of application. We as a group, we are using intrathecal application, and colleagues are using intravenous application. So in the part of your presentation, you say that this is the easiest and safest way for application. What is the level of complication in your cases? Because beside the fact that we are doing intrathecal application, but not just for intrathecal application, we are doing, because of harvesting of bone marrow, we are performing procedure under total anesthesia, and which have some risk, but luckily we didn't have any problem. But for intrathecal application by itself, we didn't saw any substrate related complications, so we didn't have any fever or things like which will be like substrate related. So I want to maybe discuss that and exchange the opinion on that way.
Thanks for the question. But it's I don't tell that the intrathecal way is bad way. It's very good way, and it's the shortest way. But in total, if you read the list of complications for the intrathecal is much more. What else you ask? It's how much we solve complication with intravenous infusion. No, we just know any complication because it's so easy procedure. It's consists. You need to put the needle or this system into the vein and start the procedure. It takes about 10-15 minutes only, and then you just go out. So just for procedure, there is no complication. At least we don't saw it. Thank you.
We in our clinic we have had a procedure intrathecal mesenchymal stem cells also, but what we observed post intrathecal syndrome. It's not depends of mesenchymal stem cells therapy. But in one of our child, we observed after intrathecal therapy high fever and seizures. And after this one case, we decided to stop intrathecal injection. And now we continue only intravenously injection, and in our studies we don't observe any difference between in the improvement between intrathecal and intravenously injection of mesenchymal stem cells therapy. But intravenously, I think it's easier. It's the first, and for children, it's not connected with big stress, and it's for me it's most safety.
Professor.
Thank you. I would like to ask both of you, since we are stereo. We are speaking about the consequences of intravenous application. My question is, have you ever checked D-dimer before and after the IV application, no matter you are speaking about the children? The other, have you ever used any type of corticosteroids during treatment? And why you of course know that most of cells, when applied intravenously, are they have their end of the way in the lungs, and they have been eaten by partially alveolar or pleural macrophage, and the 70% finishes their pathway in liver. So I understand that you have to give 50 million cells per kilo, but in our autistic patient treatment, why do you think that number of cells matters? Since we see that there are exosomes, microRNAs, microproteins that are producing effect in every part of the body, not just in the brain. What do you think about this? Does it really matter, number of cells? Do you think that just one clone of mesenchymal stem cell can release all the symptoms that the child has? It is also our question during forming treatments or talking to parents. It is very easy to multiplicate one clone of MSC, but what we are expecting of this one MSC, we know that one mesenchymal stem cell can produce 10,000 exosomes a day. Okay, how can we measure exosomal function? We know how, but do we have to give 50 million per kilo, or do we have to introduce hematopoietic stem cells in the treatment with another way of application, as I told you, intranasal application, and any other application that prevents destruction of stem cell niche or stem cell by itself before they relieve their full function?
Thank you for your question, Professor. We used not 50 million per kilograms, but we used low that 50 million per kilograms, about 30-40 million per kilograms in children. And we measure the dimers. You asked about the dimers before the treatment and after the treatment, and we don't observed any difference between before and after them. And we don't measure this macrophages and the others factors about your talk, but I think maybe in the future, because we haven't enough enough money to do this, because in Poland, unfortunately, parents pay for the treatment, and we haven't any grants to for our government to do clinical trials with measures, all what we want to measure. We only measure the function of our patients in psychological tests, and in children with cerebral palsy, the specific physiotherapy tests like GMFS test and the other. I think that maybe in the future, when I applicate for the grant, another grant from my clinic, it will be possible to check everything about that you said.
Thank you. And we have a lot of questions from the audience put forward with Zoom. The first one is cell therapy, in cell therapy, is it possible to return to the morular stage? I don't understand the question, but
what stage?
It says morular. It's probably, maybe we can ask somebody to. No. Maybe we can ask somebody to clarify. And meanwhile, the second question is, we took cells from a younger sister at birth. Can we use it for our son who suffers of ASD? I think this is maybe for stem cell probably.
Yes, they can be used. It shouldn't be a problem on that way.
There is a question that says, is it PRP? And then the answer, definitely not PRP. So I think Professor Ljubic actually answered this one. There is a question, what is the difference between stem cells and PRP? So maybe somebody can take it.
The way of using of PRP is that we can't compare these two things, because in PRP we are using platelets from circulatory blood and using the growth factors, which are maybe in percentages, maybe 3 or 4% of all regulatory and reparatory functions which can be applied. So stem cells are something totally different, and these two things can't be compared, especially if we are talking about intrathecal or even intravenous application, because intravenous application of PRP doesn't make any sense.
Thank you. This is a question for either you, Dr. Jihan or Dr. Marić. I have a son who was your patient in Novi Sad 3 years ago when he was 7. The treatment had a lot of positive effects in many aspects of his development, but he still does not speak. He is now 10. Do you think that there should be another procedure? And also, because yesterday there was a discussion about fecal transplant, can you say more about this procedure? Thank you.
Thank you for your question. Regards to patient, we think that we have our cycle, how we are doing this, how we are performing this therapy. Of course, that when we start with the project of fecal transplantation, we will first invite our all patients and see who of them wants to be involved and who are then fulfill the inclusion and exclusion criteria. So for sure, we will stay in touch with you and try to give you our best support.
Just to add something, what is important in fecal transfer, bacteria in a body produce one protein. It is called muropeptide. It can easily pass any barrier, blood, any tissue barrier, and has receptors on neural cells in the brain directly. It means that development of good fecal compounds can directly influence brain inflammatory reaction. That's why fecal transplant is basically good for restoring or remapping this immunological map in a child.
Thank you. There was also a question about FMT, so you answered it as well. Now, because I saw that we have some questions from the audience, I'm going to interrupt and give the opportunity to the floor to ask questions.
Hello. I have a question for Dr. Volchkov from Samara. I'm Dr. Tomac from Clinical Hospital Center Zagreb. I'm a transfusion specialist, and we also have umbilical cord blood bank, but we still don't have any pilot studies to treat children with ASD. My question to you is, did any of children develop GVHD later?
Thank you for your questions. No, we don't see this one because to develop GVHD, we need our cells to be engrafted. But we do not do any preparation with any immunosuppressive medicines. So, and basically we check the child's immunological system before the treatment. So we need to be sure it's okay and it's working properly.
And if I may add, for instance, in Clinical Center of Ljubljana, there was a publication when they used stem cells for treating GVHD, for immunomodulation of consequences of allogenic bone marrow transplantation, which was manifest by GVHD. They treat, I think, 9 or 10 patients, and I mean, we can share that study with you.
Yes, we use photopheresis, but we don't use this kind of.
In Poland, in our clinic in Lublin, hemato-oncology, also mesenchymal stem cells are used in treatment this GVHD after transplantation. So mesenchymal stem cells are used in treat this disease in hemato-oncology, and it's not in medical experiment, it's treatment.
And I have a little update also. So each time before the infusion and after infusion, we take some blood tests to check how much time the cells can be hosted in the patient. And we also have some clinical trial in Samara with newborns who suffered with cerebral palsy, just newborns, and they received cord blood infusion and we checked 3, 5, and I think 6, 7 days after the infusion, after the cord blood infusion, we take the blood 3, 5, and 7 days to check the DNA from the cord blood for transfused cord blood. And we, after 3 days, we see no DNA from cord blood in the peripheral blood of the patient. So maybe some cells can be hide in the tissues, but in the circulating blood we cannot find. So and the meta-analysis and other literature says it's safe. Maybe it's some kind of just one case, maybe.
Thank you. We have another question from the field.
Hello, so you come from various countries and you do different types of stem cells, but do you all agree that what the other people here in the panel are doing is overall safe to use for children?
I fully agree. We show that there is no, in both cases, we didn't show some complication except one patient from intrathecal mesenchymal stem cells from, maybe we are talking here together, I don't know, we present maybe 400 patients, but I think that all of us did much more than that. So we are talking that we have one complication in 1,000 patients. So from medical standpoint, we can consider this as a very safe procedure. Both of procedures.
Yes, I agree. It's a very safe procedure for children, and we don't observe any side effects apart this one. And we observe improvement, but not side effect.
Thank you. I will switch to. Sorry, please. If you want to.
I just want to say, so the procedure is safe, and the stem cells, at least it in many literature shows it's safe. But maybe some effectiveness not so we expect in some cases, but in some cases it's outstanding. So maybe it should be developed for some specific therapy. But I think we need to work even with this with the cells too, like in other direction too. Thank you.
I will just switch to a few. I would say that, with so many patients that, you probably have worse results giving them peanuts than this. I think it will be more frequent. The next question is for Dr. Marić and Dr. Abazovic. What is the therapeutic dose of bone marrow stem cells for intrathecal administration? How many million of SC per kilogram?
So during part of my presentation, I say that we are doing very strict calculation. This depends from patient to patient. So when we are talking about young children, we are giving all between 200 and 400 S dose and 400 millions of total nucleate cells. And they are specifically analyzed after the injection. So unfortunately, since that we are talking about autologous transplantation, when we are manipulating in the operating theater, we don't know exact number when we are giving them back, but post festum we are doing the analysis and trying to compare this.
Thank you. There is another question that actually asks or deals with how you actually measure how good the results are in therapy. So we saw that there are some standardized testing used before and after, but generally, because most of the questions here relate to verbal issues like speech and so on, is there anything that you can say even anecdotally, and especially if you have some hard evidence on what kind of improvement that can lead to?
So I will try to give, I will leave to Professor Marić because he's much better in anecdotal anecdotes. They are very specific subjective scoring, which we are using. They are neurological exams, and there are some specific analyses which we are doing from the blood and from the cerebrospinal liquid, considering the inflammatory processes. So if we are talking, if for all of the parents, it's most interesting thing to know about the result. We can say that how we follow the things in last 4 years, about 70%, a little bit more than 70% children we treat, they achieve the subjective scoring for a little bit more than 1.5 years, what the children which pass through same psychological logopeds and all the trainings which they are doing for 4 years. So what does it mean? It means that we increase the possibility for actually speed up the improvement of the kids. So this is the most important things. We have some specific scale, but unfortunately, not unfortunately, but we all know that all the patients are separate, and this is why we are using these therapies. We call them precision therapy, so we are trying to do best possible thing for that specific patient. Professor Maric.
We use what is anecdotal, I can't remember, but we use frequently with every child GAR scoring, sensory motor scoring for spasm Ashford, and neurological findings from our neuropediatrician. And we introduced lately analysis of brain hemispheres by using remote EEG device. So this is our basically 5 types of following our patients.
How I said in my presentation, we used some specific tests for children with autism, and these tests are done before the first injection and before the fifth injection in children with autism. There are psychological tests and logopedic also. But in children with cerebral palsy, we used also the specific tests using by physiotherapists, and about 80–90% of children improve in these tests. You must remember that stem cells therapy, mesenchymal stem cells therapy, and stem cells therapy must help your children. Your children don't be totally healthy without will be without autism or without cerebral palsy. But the stem cells therapy help the children and improve their functionality. If the stem cells therapy improve the functionality of your children, the improved functionality of or your families. So even it will be 50%, 60% of improvement. It's really, really big improvement for these children. So this is safety treatment, and I know that we need more and more clinical trials, more and more trials to improve that this stem cells therapy in the future will be normal therapy, no experimental therapy, but normal therapy in children with autism and with cerebral palsy. Thank you.
Thank you. We have some questions from the audience, Rasko.
Yes.
Dobar dan. Ja sam htjela da pitam da li neko od vas ima iskustva sa djecom koja imaju gensku predispoziciju za SDS, znači imamo dokazanu gensku mutaciju i koliko u tom slučaju njihove te ćelije ili neke druge ćelije koje mogu dobiti kroz ovu terapiju mogu biti značajne.
Maybe I can translate for your benefit. The question is, if there is a genetic predisposition for ASD, is there any a course of diagnostics or therapy that can be recommended in this case?
Please.
Stem cells therapy, after stem cells therapy, we observed improvement in the symptoms of autism. And it doesn't matter it is genetic or not genetic basic of autism. Now we know the most of autistic disorder are connected with some kind of genetic mutation, especially in some chromosomes. But mesenchymal stem cells are connected with improvement of symptoms of autism. So children with genetic basis of autism, they can also be treated by mesenchymal stem cells. Okay.
Good. I will add a few facts for you to know that not all the cells are genetically changed in the body. If we have some genetic involved development of a child, it means that just some part of those cells can induce production of so-called bad proteins, but the healthy ones, especially mononuclear neuroblast-like cells that exist in every mesenchymal tissue in the body, can produce healthy proteins. That means that everything Dr. Krawczyk said has sense. Mesenchymal stem cells can make good influence and give good clinical improvement. They may not treat the cause of this genetic problem, but it will improve, enhance development of the child. The issue is that we should think about this type of treatment in the early childhood because neuroplasticity of the brain in early childhood is very potent between 3rd and the 6th years of age. So no matter we have this genetic problem, clinical improvement, brain development and neuroplasticity are very potent to give good results in clinical findings of a child. The issues, if we do gene therapy like Dr. Krawczyk had, we will change genetical processes from the moment of gene changes, but we cannot change consequences that this gene left to a body. It means that a parent should think about earliest possible treatment if we have certain diagnosis of autism or similar diseases.
Thank you. We have another question from the audience.
Dobar dan, srdačan pozdrav svima. Ja sam doktorka Antin Pavlović, dečiji adolescentni psihijatar. Imam pitanje za doktora Abazovića i doktora Marića. Ja sam nekako upoznata sa vašim radom poslednjih godina, pošto i neki moji pacijenti su dolazili kod vas. I ono što me interesuje jeste, negde ste spominjali kao neke anegdotalne poboljšanja i tako dalje, ali ono što mene interesuje, da li vi prilikom procedura koje izvodite, da li imate neku, da li radite neku studiju u smislu procene dece pre procedura, koje skale koristite, nakon toga, znači koliko nakon procedure i koliko puta ponovo testirate dete i koji konkretan napredak imate kada je u pitanju govorno-jezički razvoj, kada su u pitanju socijalne interakcije, socijalna komunikacija, jer to je ono što je ključni problem kod autizma. Videla sam koleginica Magdalene da je govorila o kognitivnom napretku i to je potpuno okej. Ali šta je kada su u pitanju, znači, kada su u pitanju socijalne interakcije, takođe i repetitivni obrasci ponašanja, stereotipi i tako dalje, jer to je sve problem kod poremećaja iz autističnog spektra. Hvala vam.
Maybe I just briefly translate the question. The question is, we heard the answer about the way of measuring the success in these different therapies. But because we focused so far on cognitive tests primarily, the question is which different scales are being used, how often are the children being measured on these scales, how many follow-up iterations there are, and ultimately, do you also measure, in addition to cognitive parameters? Do you also measure social interactions, repetitive behaviors, and so on?
Ja ću onda odgovoriti na našem jeziku. Hvala, mislim, pitanje na mestu. Mogu da kažem ovako, ja sam ortoped i dečji hirurg, ja se direktno ne bavim lečenjem autizma. Mi se bavimo lečenjem procedurama regenerativne medicine, a transfer matičnih ćelija je jedna od njih. U našem timu, pre bilo kakvog starta za pre uopšte lečenje pacijenta, pacijent biva pregledan od strane logopeda, defektologa, dečjeg psihologa ili dečjeg psihijatra i neuropedijatra. Nakon pismenih izveštaja od odličnih koleginica, pacijenti razgovaraju sa mnom ili sa doktorom Abazovićem o mogućnosti da li će matične ćelije na neki način imati mogućnost da poboljšaju stanje deteta. Do mog znanja, koje nije svakako na vašem nivou, je GARS skala, senzorno-motorna skala, se koriste bukvalno u evaluaciji na svakih mesec dana do 12. meseca od prve transplantacije ili 6 meseci od poslednje transplantacije. Sam protokol obuhvata 3 transfera autolognog bone marrow aspect concentrate na mesec dana. Naravno, znači i neuropedijatar vrši kontrolu pre i na kraju lečenja. Smatra se, zašto je na mesec dana, smatra se da akumulirana aktivnost matičnih ćelija koje mogu da žive i 3 nedelja, mogu i 6 nedelja i 12 nedelja, traje aktivno do 6 meseci nakon poslednjeg davanja i smatra se da ako je suđeno da one nešto donesu novo kod takvih pacijenata, da je to vreme kad moramo da vidimo neko poboljšanje. Znači, direktno praćenje od strane drugih specijalnosti, to sam rekao juče, svakako mora biti, neophodno je. Ono što se tiče neke moje direktnog stanja, znači analize hoda, neuromuskularne aktivnosti, hiperkinetskog dela, to je više manje standardno u dečjim ortopedskim procedurama, jasno, ali to nije vodeći simptom kod autizma, kod dece sa simptomom autizma. Ono što smo uključili je i gastroenterolog, pošto određeni broj dece pre i posle imam detektovane probleme sa digestivnim sistemom, od preosetljivosti, dijareje i tako dalje, koji nakon inicijalnih davanja promene svoj, tako kažem, mikroživot creva, tako da i gastroenterolog može da svoje mišljenje ima. Ja sad gastroenterološke analize detaljno ne poznajem, ali principijelno se izbegava, koliko shvatam, davanje ekstremnih lekova, bioimunoterapija, ako nije neophodno, i uloga matičnih ćelija bi bila svega toga da što ranije moduliše imunološki odgovor. Znači, odgovor na vaše pitanje je to da svakako pre 6 meseci, 12 meseci imate multidisciplinarnu, bar u našoj ustanovi, i naravno to možete uvek sa koleginicama porazgovarati o tome, imate kontrolu pacijenta na taj način.
I samo da se nadovežem, ako dozvolite, pošto je moj dio se tiče nekih analiza bazičnih, svaki pacijent ima urađen imunološki profil, ima standardne analize i svakome je rađena striktna fenotipizacija iz kosne srži i posle u aspiratu koji je dat i prate se sistemski i citokini iz likvora, znači njih 17 posle 1., 2. i 3. mjeseca davanja.
How I said in our protocol, in our treatment, every patient with autism has had before the first injection the tests and psychological and logopedical tests. The next test is before the 5th injection. The next is 3 months after 5 injection, and the last one is the 6 months after the 5th injection. And this is some kind of follow-up to show our improvement in our still and in this follow-up, we see that what we do after 5 injection, we have still after 3 and 6 months after mesenchymal stem cells injection. Of course, these children still needs the therapy because not only stem cells therapy enough, they must be also during this the therapy by psychologists, occupational therapists, and logopedists.
I will just, thank you. I will just briefly interject here because I see someone, you're still holding the microphone. Just please give a round of applause. Dr. Jihan has to leave now and we will continue the discussion, but just to...
Thank you very much, everyone.
So I see another question. Is there another question from the audience and organization? How much time we have left? 5 minutes, okay? Please.
Dobar dan, moje poštovanje. Ja bih imala par nedoumica, pa ako biste bili ljubazni da mi odgovorite. Da li postoji određen broj aplikacija koji vi preporučujete? Pretpostavljam da matične ćelije ne mogu da se primaju u nedogled. Da li postoji neki određen broj i kako odlučujete koji broj aplikacija je dovoljan nekom detetu? I moje sledeće pitanje, pošto je moje iskustvo tako, moje dete je primilo matične ćelije, ali kod određenih klinika su kontraindikacije za primanje matičnih ćelija epistatus, a određene klinike kažu da to apsolutno nema veze, pa me to sad onako malo zbunjuje, pa eto ako biste bili ljubazni da nam pojasnite malo. Hvala.
I will just briefly translate. The question is, how do you decide how many applications, how many times you will use stem cells? We assume that it's not possible to use them indefinitely. So how do you select how many treatments you will give to a child? And is there an exclusion criteria on the basis of epilepsy, if I understood correctly, for the stem cell treatments? Yeah, please.
About epilepsy, it is exclusion criteria. Drug-resistant epilepsy, because after stem cells therapy, the stem cells therapy may, after this therapy, it may be more and more attacks, because stem cells are some kind of psychostimulation of the brain, yes, and it's maybe more attacks after stem cells therapy. It is also the protocol from USA, from Professor Kurzberg. On this protocol, it is our basis. And if there are 5 injections, how I said, and if we observe improvement after this 5 injection, we must repeat the next 5 injection, but about 4-5 months after the last injection. And almost all our parents and children, and our children have more than 5 injections of mesenchymal stem cells, children with autism, but without epilepsy.
Samo ukratko, principijalno, matične ćelije, ako su autologne, one i koriste se ove procedure koje su kolege opisali, ove naše, principijalno nemaju kontraindikaciju za neograničen broj primanja, jer se radi transfer s jednog dela na drugi. Ključ samog transfera je što mozak utiče na kosnu srž da izbaci u cirkulaciju određen broj matičnih ćelija, što radi svakodnevno kod bilo kakvog imunološkog incidenta, povrede i tako dalje. Ključ davanja koncentrata autolognih matičnih ili velikog broja mesenchymalnih matičnih ćelija jeste da vi koncentrisano date ciljano u jedan sistem veliki broj aktivnih proteinskih supstanci koji mogu da utiču na uspavane matične ćelije, uspavane procese, gensku kaskadu, krvno-sudovnu arborizaciju i tako dalje, koji mogu da daju određeni rezultat. Što se tiče same epilepsije, sama epilepsija je stanje za sebe, vrlo kompleksno i ja nisam, naša profesorka je profesorka Knežević-Pogančev iz Novog Sada, ekspert uopšte na evropskom nivou za epilepsiju, mi se ostavljamo na njen nalaz. I ako ona kaže da kod pacijenta sa ovakvom tipom patološkog EEG-a ili epi napada možemo da uradimo transfer, mi uradimo. Ako kaže ne, mi ne uradimo. Ali iz našeg iskustva jeste da kod rođenih pacijenata koji su imali po 20-30 napada dnevno, nakon transfera koncentrata kosne srži je došlo do poboljšanja, recimo da imao jedan napad na dan ili po 7-10 dana nema ni jedan napad. Kod nekih pacijenata nije bilo promene, ali nisu ni bile lečeni primarno kao epinapad, kao epilepsija, nego neki drugi uzrok. Ali znači zaključak je da autologni transfer matičnih ćelija nema neki limit, da je bezbedno po dete. Neće uzrokovati tumor ni u literaturi, ni u našem iskustvu ili nešto drugo, ako se daje ovako kako jeste.
Dobar dan. Hello, I have a question for Dr. Krawczyk. As a follow-up to this, you said drug-resistant epilepsy would be an exclusion criteria according to you, but drug-manageable epilepsy then is not an exclusion criteria according to you and your
Yes,
clinic.
if I have a patient with autism and epilepsy, and for example, this is one seizures attacked for example, 2, 3, 4 months, it's only one drug. It's not drug-resistant epilepsy. Drug-resistant epilepsy is attacks almost every day or a few attacks for 1 week, and children need 2, 3 anti-epileptic drugs. It is drug-resistant epilepsy definition, yes? It is epilepsy, but the seizures are one for a few months. It's not drug-resistant epilepsy. And I, of course, I used mesenchymal stem cells therapy in these patients, yes? But now I know that probably in the United States now are the clinical trial to use stem cells therapy in epilepsy. So we are waiting for the results and we will see what will be in the future.
Thank you. I think that...
we have one more question to ask. I'm so sorry, and we'll be done.
See you. Yeah.
Dobar dan svima. Pa postoji jedna vrsta polemike među roditeljima i roditeljskim grupama apropo toga da li treba uraditi transfer matičnim ćelijama iz koštane srži ili iz Pupčanika. Da li je ta dilema opravdana po vama? Tačnije, da li postoji, kada procenjujete dete, neko dete kojima bi rekli da vi radite iz koštane srži ili vi radite iz Pupčanika, ili mislite da bi dete podjednako reagovalo bilo da je jedan ili drugi tretman? Hvala.
Just a brief translation, but I think all the words ring a bell. The question is, because there are two main types. One is extraction of stem cells from bone marrow, and the other one using the cord blood. So are there any instances, because some of the parents are debating this issue, are there some instances in which you would recommend one or the other for a specific condition of a child in question? Or is it completely the same? So, $1 million question.
Yes, if it's so easy, but there is still clinical trial. We don't even know how much in our trial we can try to give the answer about what is better in cord blood. It's high or low HLA matching, or even because our first clinical trial was without any matching. And we also show good results with ASD in cerebral palsy patients. But you ask what cell types, cord blood or bone marrow, what is better for which instances. So I don't think somebody can ask you these questions because we are not always can predict the results of any transfusion of cord blood or bone marrow or even else. So we just know the percent of success rate and the percent of non-responders, and we even not even in each time we know what's the reason of the failure. So I don't think somebody can answer these questions, but maybe colleagues can. I don't know. I can't. Sorry.
I think you're right. This is a cutting-edge procedure nowadays. Each institute of yours and our clinic, we are trying to make the best possible protocol for the child, for the persons. It means that if allogenic stem cell MSC work, I really agree. But as we concluded before, it is related to financial resources, and sometimes it is almost impossible to get enough resources to have good clinical study. But since we have some good, even in Poland, we have exchange experience before, I think first before 4 or 5 years, that they also used autologous bone marrow aspect concentrate with the same success rate as we have.
Autologous, yes.
And it means that it is different from patient to patient. And of course, we should strive to make the best optimum protocol for each child, because there is no two same patients and no two same responses, no two same procedures, two same DNA or genetic basis. So this question will remain open to maybe next few decades to be generally defined what is the best protocol. But we think that whatever we should do something multidisciplinary with those children, not to wait too long.
Okay, maybe
I just want to personally thank you for explaining everything you've done today, explaining that there's no magic pill for autism with stem cells, but also highlighting that there are improvements. Tatiana and I, as co-organizers in front of Autism, also run a forum for parents that talk about these things, that we really wanted to take this opportunity to kind of say that there are some answers out there. If you have more questions, you can certainly look for it in our group. The group on Facebook is Terapija matičnim ćelijama za djecu. And hopefully any follow-up questions, maybe we can answer through the group. So thank you. And thank you for everybody. Rasko, take over.
Yes, she took the microphone, so that means I'm completely over time. I also wanted to thank you for this, but please sit because we'll have a presentation. Just wanted to also wrap up by saying, number one, this is safe. I think this is conclusion number one. Number two, it's not the magic bullet, but it's worth trying, and I think so many experiences show us that. And number three, this is one of the fields where instead of kind of competitive forces between different hospitals and scientists and so on, we have a lot of collaboration, and we saw that even here on the panel. So I want to thank you personally, and keep up the good work and try to find something extraordinary sometime soon, hopefully. So please, and please keep your seats. And now we have Christian Martin, who is from the Chief Medical Officer of the BioSave Foundation. He will speak about the support in treatment with stem cells.
Working, right? It will be in native language, but I can introduce myself in English and say hello. My name is Christian Martin. Christian is the name, Martin is the surname, like the Ricky Martin, just the Kiki Martin. Also, I'm the medical director of the BioSave Foundation. I want to thank all of you to Let me introduce our company, our foundation. I'm not gonna talk a lot about my portfolio or references, but I hope that this presentation and this story will give a little bit of inspiration to all of you, because sometimes it's just about a tiny dose of inspiration we need all. Dobar dan. BioSafe grupa ove godine obeležila je svoju prvu deceniju postojanja. Osnovani smo 2012. godine u Beogradu sa željom da... I prepared in native language, so sorry. Osnovani smo 2012. godine u Beogradu sa željom i vizijom da budućim roditeljima u Srbiji pružimo najkvalitetnije usluge u pogledu skladištenja matičnih ćelija iz krvi Pupčanika kao jedan vid preventivne zaštite i time omogućimo brojnim porodicama u Srbiji i regionu da neku vrstu bezbrižnije budućnosti. Iste godine smo pokrenuli i BioSafe u Makedoniji, potom i Crnoj Gori, zatim Bosni i Hercegovini i Hrvatskoj. Slovenija nam se priključila 2014. godine, a potom smo 2018. godine januara osvojili i Albaniju, tako što smo otvorili predstavništvo u Tirani. 11. predstavništvo je prošle godine startovalo sa radom u Banja Luci, te smo na taj način prisutni kao apsolutni lider u oblasti na teritoriji cele bivše Jugoslavije, a i nakon 10 godina rada rastemo i pratimo najnovija dostignuća koja se tiču pre svega biomedicinskih nauka, genetike i regenerativne medicine. Naša danas kompletna timska organizacija BioSafe-a čine pre svega lekari, pedijatri, potom molekularni biolozi, embriolozi, patronažne sestre, babice, tehničari i mnogi drugi, što našoj kompaniji daje na neki način sveobuhvatnu multidisciplinarnost i stručnost o brizi zdravlja savremene porodice kao i oni koji svoje porodice tek planiraju. Imati mogućnost da pomognete nekome i makar malo ulepšate ili olakšate svakodnevnicu i život je po meni privilegija. Osjećaj odgovornosti da pomognemo nekome je odličan način zapravo da ojačamo sopstvene lične vrednosti, daje nam osjećaj svrhe, daje nam osjećaj smisla, pripadanja zajednici, čini nas boljim ljudima. A dobri ljudi pravi i dobre ideje. Na osnovu ovih principa, kao društvena odgovorna kompanija 2013. godine oktobra, osnovali smo fondaciju za pomoć pri lečenju matičnim ćelijama, zajedničkom inicijativom BioSafe-a iz Beograda i ostalih ogranaka, i to pre svega sa željom da porodicama iz Srbije i regiona pomognemo u započinjanju procesa lečenja matičnim ćelijama. Savjetovanje i inicijacija procesa terapije matičnim ćelijama, bez obzira u kojoj banci roditelji čuvaju uzorke svojih novorođenčeta, odnosno svoje dece, podrška, komunikacija sa inostranim klinikama i ekspertima iz oblasti primene, prevod medicinske dokumentacije, ali i samo aktivno učestvovanje tokom same terapije i praćenja benefita iste su samo neki od zadataka koji naš medicinski tim ima. Moram da napomenem da gotovo sve do 2021. godine naša fondacija je dobijala samo povremene, sporadične upite za lečenja, ali bez aktivnog učestvovanja nas samih u realizaciji lečenja, odnosno prisustvovanja u samim lečenjima. Sa željom da unapredimo i svoje znanje i da unapredimo veštine i da intenziviramo rad naše fondacije, postali smo učesnici najvećeg svetskog kongresa u primjeni matičnih ćelija iz krvi Pupčanika, Cord Blood Connect, koji se održava svakog septembra u Majamiju, u Sjedinjenim državama. I moram da napomenem da je BioSave fondacija jedina organizacija iz regiona koja je bila prisutna u prethodne 3 godine na ovom kongresu, što će biti slučaj i ove godine septembra. Prisustvo na ovom kongresu nam je pre svega omogućilo poznanstvo i prvi korak u otpočinjenju saradnje sa stručnim medicinskim timom Duke univerziteta, koji vodi, spomenuli smo već, profesorka Joana Kurzberg. Doktorka je pionir u lečenju matičnim ćelijama, inače učesnik prve transplantacije matičnim ćelijama iz krvi Pupčanika koja je bila 88. a danas pre svega se bavi neurološkom problematikom, odnosno terapijom matičnih ćelija u slučaju neuroloških stanja. Uz njenu podršku i podršku njenog tima uspeli smo i da organizujemo prvu terapiju deteta iz Srbije na Duke univerzitetu. Pored svih restrikcija i poteškoća u pogledu mera koje je donela COVID pandemija, na globalnom nivou ohrabreni smo bili tom prvom uspešnom terapijom, odnosno organizacijom, i to nam je dalo vetar u leđa, tako da 2021. godina postaje prekretnica u radu naše fondacije. Činjenica na koju smo posebno svi mi ponosni jeste da smo tokom prošle godine u periodu od aprila do septembra uspeli da organizujemo terapije za 5 mališana iz regiona, iz Srbije, iz Crne Gore i Hrvatske. Deca su bila starosti 6 do 9 godina, a tretirani su autizam i cerebralna paraliza na klinici Hemafund u Kijevu u Ukrajini. Što se tiče same terapije, kako sve to funkcioniše? Ukratko, pre same terapije, mada su profesori već pričali o tome, svako dete prolazi kroz preglede više specijalista. Dakle, uključeni su psihijatar, uključeni su psiholog, neurolog, fizijatar, defektolozi, logopedi, a potom se radi specifične biohemijske i imunološke analize. Naravno, nakon toga ide i procena opšte zdravstvenog statusa deteta pre otpočinjanja same terapije, a nakon saglasnosti lekara za otpočinjanje terapije vrši se pristup u istoj, koja obično ide na 2 načina, ili intravenski ili intratekalno, odnosno u kičmeni kanal. Precizna procena napretka deteta nakon terapije vrši se nakon 6 meseci. BioSave fondacija je na ovim terapijama na samoj klinici pratila sprovođenje i sve terapije su prošle veoma zadovoljavajuće kod svih mališana i bez bilo kakvih neželjenih dejstava. Dešava se 2022. godina i našem timu donosi nove izazove. Nažalost, pred gotovo sam početak realizacije programa početkom godine za lečenje još 4 mališana iz regiona u Kijevu, situacija u Ukrajini nas sprečava u poslednjem momentu da ove terapije sprovedemo u delo. Alternativu za 3 mališana, na moje veliko zadovoljstvo i na zadovoljstvo svih nas, uspeli smo da pronađemo kod naših stručnjaka u Srbiji. Ja se iskreno nadam pozitivnim ishodima ovih terapijama i bit ćete, kada se sve završi, obavešteni o istim. Umeđuvremeno, trenutno smo u razgovorima sa pojedinim institucijama u Turskoj, ali i u Poljskoj, u kojoj čekamo na neki način restartovanje programa za terapije autizma i cerebralne paralize, obzirom da je program blago usporen, ako ne i stopiran, sve zbog same COVID pandemije. BioSave fondacija i BioSave ostaju dosledni svojoj misiji, posvećeni podršci svim porodicama iz regiona kojima je potrebna pomoć i najiskrenije se nadam da će i Srbija uskoro dobiti prvu banku matičnih ćelija, pre svega da bismo enormno olakšali proces terapije onima kojima je to najpotrebnije. Iako početna dijagnoza autizma kod deteta nesumnjivo menja život kompletne porodice, duboko verujem da uz odgovarajuću terapiju, uz odgovarajuću podršku svih nas, sva deca mogu imati lepu budućnost. Medicinska nauka je evidentno napredovala i dalje i brže u posljednjih 30 godina nego ikada do sada, a tempo je u posljednje vreme praktično galopirajući. Spomenuli smo da matične ćelije nisu nikakva magična pilula ili magični štapić, ne treba na to tako gledati, ali medicina matičnih ćelija ima potencijal da pruži odgovore na neka od možda najupornijih problema i medicinskih pitanja sa kojima se susrećemo i verovatno da ima mogućnost da da odgovore na ova pitanja pre nego kasnije. Za decu ove generacije koje su rođena ili koje će biti tek rođena u svetu u kome nauka može na kraju imati mnogo više odgovora nego pitanja, je možda jedan od najvrednijih poklona koji možemo, ali i koji smo svi dužni da pružimo svoj deci. Hvala vam.